Hello there. My name is Grayson Armstrong, and I'm a comprehensive ophthalmologist at Mass Eye and Ear. I'm the director of ophthalmic emergency services, and I'm an instructor in ophthalmology at Harvard Medical School. Today, I'll be talking to you about an introduction to the slit lamp examination. My disclosures are that I co-founded a company called Ocular Technologies, which their technology will actually be highlighted as an educational tool later in this lecture. Learning objectives for today are to first understand the utility of a stereoscopic slit lamp. Second, to appreciate various slit lamp techniques to evaluate eye anatomy. And third, to observe a full ophthalmic slit lamp examination and review common ophthalmic clinical findings. So the slit lamp is basically a microscope for the eye. We need to magnify the eye and look at it in high detail in order to find evidence of disease. However, let's take a step back and think about how a microscope works. Now, a microscope is normally looking at a two-dimensional object, usually a piece of tissue or an object on a slide. So that slide is obviously cut very thin and it's two-dimensional. Now, if you're looking at that slide underneath a microscope and it's out of focus, what do? Well, it may seem obvious, but you turn the knob so that things come slowly into focus. And so makes sense. We need to focus the image. But what about brightness? Let's say that the image is overly saturated with light. Well, if that's the case, we turn the knob to decrease the brightness. If we go too far, then it gets too dim. And so we turn the knob the other way. And so we control the brightness level as well. Now, it may seem simple that you can get an image in sharp focus with good lighting when you're in a two-dimensional plane. But what about the eyeball? The eyeball is a three-dimensional object. And so at any given time, the microscope is in focus at a single point, which may or may not be what you're trying to observe. This may make things that you're interested in out of focus, and the light may be too bright or too dim to see what you want. So how do we control this? Well, we can think about the eye as a stack of two-dimensional images. Here you can see a random image that I found on Google, a very slide deck that's, three-dimensional in nature. And so if we're looking at those slides that are three-dimensional, and we see that the first one is in focus, but we're trying to see something behind it, all we have to do is turn the knob, and again, it focuses backwards. And so we can go forward and backwards to look at things that we want to see by turning the knob. The eyeball is three-dimensional, as I mentioned, and so we want to be able to see things in front and behind. Unfortunately, the slit lamp doesn't have a knob that focuses back and forth, so we'll need to manually control the slit lamp to make sure that we can evaluate things at all depths of focus, and we'll talk about that in a second. So let's imagine we're sitting now in front of the slit lamp, which we will be together soon. First, we need to know that the on-off switch is at the bottom hand corner of the slit lamp, usually a green knob. Sometimes there's a turning, twisting knob. Some slit lamps differ a little bit, but first things first, make sure you turn on the slit lamp. Second, what we need to know is that the light source is at the top. So it can get hot and just don't touch it, but this is where the light is coming from. When you ask the patient to come into the slit lamp, you need to know that the corner of their eye needs to be lined up with a black line at the corner of each of these metal bars. In order to make sure that it's aligned, you can actually turn this wheel to raise the patient's chin up or down. This should align their eye to the corner of the black line. Now look through the oculars. This is for you to look through. The oculars are the perspective viewer of the slit lamp microscope. If you need to move things around, you can take the handle in your dominant hand and move it back and forth to move it in the XY axis, but to move it up and down, you actually rotate. If you rotate it clockwise, everything moves up. If you rotate it counterclockwise, everything moves down. Now, because you don't have a knob for focus, things in a three-dimensional structure are actually manually focused by moving the knob towards what you're looking at. If you're too far away from the eye, it will be out of focus. So you slide the slit lamp closer to the patient's eye, and that should bring things in focus that you're interested in observing. Now, we should know that there's a knob here that you should always hold with your non-dominant hand, and it changes the width of the slit lamp by twisting the knob. You can swivel the light source and the oculars back and forth to change the perspective of the eye. There's a magnification wheel on the side of the slit lamp that can change, how zoomed in or zoomed out the image of the eye appears. There is a knob at the top here. It's a silver little round knob. And if you turn it to the right, it increases the height of the slit. And if you turn it to the counterclockwise direction, it decreases the height of the slit. And lastly, if things are too bright or too dim, there's also a knob at the bottom of the slit lamp that can change the light intensity. I recommend that during a slit lamp examination, you perform all the steps and examine all the structures of the eye systematically. This way you never miss anything and you always make sure to evaluate each structure individually. We will start with the lids and lashes and the periorbital skin. Next, we move on to the conjunctiva, the cornea, the anterior chamber, the iris, and the lens. So let's take a moment to step back and talk about why this is called a slit lamp microscope. The value of this machine is that it can create a slit of light as opposed to a broad diffuse light. Otherwise, we could just use a flashlight or a pen light to observe the eye, as we can here on the left-hand side. However, you can see that things are, at least in this image, two-dimensional. It's hard to get a sense of depth. For instance, is that white mark here on the cornea? Or is that in the iris? Is it something floating in the anterior chamber? Technically, it's a little hard to tell. But if you make a slit, as it is on the right-hand side here, you get a better sense of depth. You can see that the light source is hitting first the cornea, then it's floating through the fluid of the anterior chamber, then hitting the iris and eventually the lens. We'll go into more detail about that later, but it's just worth knowing that the slit is worth its weight in gold in evaluating the depth, thickness, and size and shape of various structures of the eye. Here we can find that the slit of light that's hitting the eye is at an angle. I show you this model because what I'm going to do throughout each step of this video is give you a diagram of where the slit of light is pointed and whether it's a thin or a thick slit of light. In this image, we have a thin slit of light at an angle, hitting first the cornea, going through the fluid, and hitting the iris. You can see the same thing here. It's going through the cornea, through the fluid, and hitting the iris. So this is a diagram for what this is showing you in real life. So how do we make the slit of light? We did talk about this a second ago, but I want to make sure you understand this because it's important. When you sit down to the microscope, you have your patient in front of you, the lamp is turned on and ready to go. You want to create a beautiful slit of light like this. First, what you do is you use this little knob to decrease the width of the slit of light. If it's broad, you bring it to the smallest slit of light that can still be seen. After that, we swivel the whole thing to the side to make it at an angle so it's not pointed directly at the patient. And lastly, you slide everything side to side to move the slit of light over the cornea, if that's what you're looking at, or maybe it's the iris or the lens, what have you. So let's start with our systematic evaluation. First, we're doing the lids and lashes. Here you can see that we're using a broad beam of light, and we're focused on the skin and the lashes. Now, this is a high magnification view of the lids and the lashes, and if you were just looking grossly at someone's eye and weren't paying attention, you might not notice that there are little tiny crusty stuff on the lids. And if there was a pimple or something on the skin like a cancer, you'd be able to find it in high magnification. Here's some examples of things you might see. In the top left, you can see that there's damage to the eye. It looks like it was lacerated and the eyelid skin was split in half in the top and the bottom. Luckily, it looks like the eyeball is okay. But if you needed to look at this in high detail, you can under a slit lamp. Obviously, a broad beam is useful for this. You don't need to find a slit or any three-dimensional nature of this. In the bottom left-hand side, you see a chalazion or a hordeolum, commonly known as a stye. This is very common. And if you do look at this under a microscope, you can sometimes see where this is emanating from and how you might want to fix it. An example of what you're also looking for is looking at the eyelid margin, right at the edge. Now, everyone has little tiny meibomian glands that secrete oil onto the eye. When they're healthy, you shouldn't really see much of anything other than teeny tiny little holes here at the eyelid margin, a little bit behind the eyelashes. But if the oil gets thickened or they have dysfunction of these meibomian glands, then it gets thick and it looks like this thick oily substance. And if these get blocked up, then you get a stye. That's actually what this stye is caused by, is a blockage and backup of oil inside the eyelid. You also see that on this patient's eyelid, there's a lot of yellow crusting stuff. This is called blepharitis, and it's a sign that the patient has a buildup of oily debris that's inflammatory on the eyelashes that causes irritation, redness, burning, and sometimes crusting in the morning. Next, let's move backwards to the conjunctiva. You can see in our model that we're using a broad beam of light focused on the conjunctiva. Here you can see a picture of the conjunctiva. The broad beam of light gives us an overall view of the surface of the eye here. What are some of the things we look for? Well, because we're using a broad beam of light, we don't need to necessarily assess depth or structure function. What we do see here are big papillae, usually from bacterial, viral, or other etiologies. These are kind of growths and inflammatory reaction of the conjunctiva. Here you can see what's called a pterygium, which is an overgrowth of skin, usually caused by sun damage, and it overgrows onto the surface of the cornea. You can imagine that if this hits the center of the eye, it actually causes visual dysfunction. And lastly, we see a subconjunctival hemorrhage. This is bleeding underneath the conjunctiva, but on top of the sclera. This can be random and usually is not dangerous unless it's associated with more major trauma. And as you can see, it looks relatively flat. There's no active bleeding. It's not spilling blood over the eyelid. You also notice that because it's stuck underneath the conjunctiva, it can't go past onto the cornea or into the eye. And so it stops here and it's not visually significant. We can also use a broad beam of light on the cornea. So we see that in the eye model, we see a broad beam of light focused on the front of the eye, the cornea. If we use normal colored light, you can see that it has a nice healthy reflection here on the left-hand side, but we have instilled fluorescein dye into the eye. And the fluorescein dye, if we turn the light green or blue, sorry, if we turn the light cobalt blue, it causes the fluorescein dye to fluoresce, hence the name fluorescein, and it turns green here. So in this next example, we'll see what that is useful for. If we start on the top left-hand side, we see these little tiny bulbs or dendritic pattern staining. These are supposed to be green, but it's a little washed out with the light, the picture. What this is actually herpetic infection with dendrites on the surface of the cornea. So if you had instilled fluorescein and you looked at this with blue light, you would see these little tiny dendritic patterns. This can be from HSV, VZV, or others. The top right shows little tiny white stains on the surface of the eye. Because this isn't a slit, we don't know exactly where these are located. Are they on the surface, in the stroma, on the inside of the cornea, or even in the anterior chamber. But I will tell you for the purpose of this that it's on the surface, and these are small scars on the surface of the eye. Collections of inflammation, perhaps, that can be caused by overuse and damage from contact lens wear. In the bottom left, the broad beam of light shows us that there's a white ring around the edge of the cornea, and this is called arcus senilis, usually caused by cholesterol deposition or lipid deposition in the peripheral cornea and associated with age. And lastly, down here, we see the cobalt blue light again has stained a large corneal epithelial defect. It's worth knowing that the cobalt blue light on the lamp is very useful for evaluating epithelial damage because the fluorescein will only stain areas that are damaged. It will not stain areas that are healthy. And hence this whole area has been scratched, perhaps by a fingernail or something else. Now, let's get to the fun part. The reason why we call it a slit lamp in the first place is to create a slit of light. This image is familiar to you. We showed it to you earlier, but just as a reminder, what we're doing is we're creating a small slit of light, angling it, and we're looking and focusing specifically on the cornea. Now, what's the value of this? In the top left-hand corner, you can see that the slit of light is coming from our left and going towards the right. You can see the epithelium of the cornea here. The stroma is all here. The endothelial layer is here. The fluid is here, and then you can see the iris behind. Because we're focused on the cornea, you can see the anatomic structure, three-dimensional structure of the cornea, which is sometimes useful. For example, in the bottom picture, we see a corneal ulcer. It looks devastating. It's nice and soupy white, infected, but what you can see is that at the top and the bottom, you see the nice epithelium, stroma, and endothelium. But what happens when we get to this, the ulcer? Unfortunately, the ulcer has caused thinning of the cornea, and we see that instead of being bowed out like a healthy cornea, it's actually diving in, and it has a depression in the center of the ulcer. Corneal ulcers, if they get bad enough, can actually thin so much that they perforate the eye, and the intraocular contents can leak outside. And so these are emergencies and need to be treated immediately. We can also see that in the top right picture here, we see the slit in high magnification. We see the epithelium, the stroma, and the endothelium. But we see that on the endothelium, there are these little tiny white balls of collected material. These are actually inflammatory debris from uveitis. These are called keratic precipitates, or KP for short. Keratic precipitates are white cells that have collected on the inside of the cornea whenever you have inflammation in the eye. And because of the slit, you can tell it's on the inside of the eye, not on the outside or in the stroma. and this helps give us guidance on what we're looking at and the anatomy of what's going on. Next, let's look at the anterior chamber, which is the fluid of the front of the eye. What we'll do here is create a small slit, about a 1x1 box, by decreasing the height and the width, and then we're going to focus on the fluid of the eye here. As you can tell here, it's in high magnification. This is actually a beautiful image because normally the fluid is empty and clear in a healthy human. But whenever there's inflammation or bleeding, you sometimes can actually see the individual white blood cells or red blood cells floating around. And in this case, you can actually see the white dots floating in the anterior chamber. This can happen after surgery, which we expect. It can happen with uveitis or inflammation. It can happen with infections or other causes. So just remember this. This is what we talk about with cell and flare. We'll talk about this more in a second. Let's talk about how to make this small box again. I want to make sure that this is clear for everyone. So first, what we do is we change the slit lamp height, which is here. By turning the knob, we increase the magnification on the slit lamp itself to zoom in on the eye. And then we increase the light intensity to the highest setting because it's going to need a lot of light to reflect off of these little tiny white specks and little tiny red blood cells if they were there. So what kind of things do we see in the anterior chamber? Well, in the top left-hand side, we see that it hits the cornea on the left. Oh, well, let's talk about this again. So we see that this is a beam of light coming in at an angle. We're focused on the fluid in the anterior chamber with a bright beam of light, high magnification. We see that in this top left picture, it hits the cornea first, the light passes through the fluid, and then goes onto the lens or just behind the iris. You can kind of imagine that there's a little bit of a smoky appearance. The way I think about this is kind of a smoke and debris in a movie theater when you see the light casting from over your head. This is called flare, and it's very mild in the top picture, but it's very intense in the bottom picture, where you can see that that entire beam of light is casting a shadow and a bit of a haze that you can actually structurally see. Flare is due to proteinaceous material floating in the anterior chamber that normally wouldn't be there. Normally it would be completely clear and fluid. Whenever you see flare, it can be a sign of inflammation. As we mentioned before, we talked about cell, which we saw in the last picture, but if it gets bad enough that you have so much cellular debris and white blood cells collecting in the eye, then it settles down like a snow globe where it's not shaken anymore. And it settles down in the bottom. It causes something called a hypopyon. I know this is a blurry image, but hopefully you can see that this is a white collection of material in the bottom of the eye there. And if there's bleeding in the eye, we call it a hyphema. And this is a collection of red blood cells that have settled down as well. One of the beauty features of the slit lamp exam is that the machine can increase the height of the width of the beam. And you can actually use that to measure the height of a hypopyon or a bloody hyphema, or any other structures really. So what you want to do is use the beam here, increase the width and the height to match the structure that you're trying to measure. And up here on the top of the machine, it actually gives you in millimeters the size of what you're looking at. So you can track this over time to see if there's more or less bleeding the next time you see them. Now let's look at the iris. The iris is such a beautiful structure. This comes from New England Journal of Medicine, a nice little crypt in the iris. What we're doing is using a broad beam of light focused on the iris surface. Things that you might look for in the iris are small little tears from blunt trauma. These are called iris sphincter tears. They can be associated with bleeding and trauma. Here in the top right, you can see that the iris has actually become disinserted from the inside of the eye and it's folded over. This can be due to blunt trauma or otherwise penetrating trauma sometimes. This can be surgically repaired if necessary. And in the bottom picture, you can actually see a big nevus. And so again, you can measure the size of the nevus in various planes, maybe vertically and horizontally, record that, and then you can track it and see if it's growing or changing over time. There's also a unique feature of a slit lamp. And the way I think about this before you look at this picture and get too invested is, you know, if you've taken pictures of people with your phone or a fancy camera, but then they have these red glow of the eyes, like a red light reflex. Well, that's exactly what's happening here when we point the light directly into the eye, facing the patient, and it's having the reflection come directly back at us. Again, we're focused on the iris, but this is called retroillumination. It's a technique that's a little bit more advanced, and if you can do this and show your attending that you saw something on retroillumination, they're going to think you're a genius. So point the light directly into the eye. You usually want a small little beam of light, relatively bright, It will be very bright for the patient. Just realize that they're going to be a little uncomfortable during this, but you shine it into the eye and look at the iris. In this case, you can see small defects in the iris. These small defects are following the pattern of the stroma of the iris, and this is actually due to something called pigmentary glaucoma, where you lose pigment from the iris, and that pigment floats around in the eye and clogs up the drainage system of the eye and can cause glaucoma. So this is a unique finding in something called pigmentary glaucoma. Now let's talk about the lens. What we're doing here in our eye model is having a beam of light off at an angle, but we're focused on the lens itself, the crystalline lens of the eye. And so having this at an angle is useful because we can actually see the structure of the lens itself. This is always a little confusing. It took me a while to learn when I was a med student and a resident as well. So I wanted to give you a little bit more of an overview of what we're talking about. This is the structure of a crystalline lens. You can see that there's a surrounding capsule holding the lens. There's an anterior pole, and the back is the posterior pole. And there is a cortex off to the side and a dense nucleus with nuclear fibers. Here it is in the eyeball itself. You can see that it's held in place by these losannules, but we see the outside cortex, the rings, and then the core nucleus. When we shine a light at an angle, what we're doing is we're having the light perform a cross section, kind of like a CT scan of the lens. And it goes from front to back. And here we can see that it's going through the cornea, the fluid, through the pupil, and then through the front and back of the lens. So what does this look like? What does this look like when we're evaluating the eye? Well, first, we see that the light is hitting the cornea. So this is the corneal reflex. It's out of focus because we're not focused there. We're focused behind it by pushing the slit lamp forward towards the lens. But I've highlighted it here so you see what we're talking about. Next, we see that it goes through the fluid and it hits the iris up here and down here. Now it continues on and it hits the lens itself. The whole lens from front to back is shown here. And notably, the front of the lens is the first thing that the light hits, which is here. The next thing, it goes all the way through and hits the back of the lens back here. This is just to give you a little bit of a sense of what we're talking about and looking at. And then the nucleus in this patient is actually visible. It's usually not so prominent, especially in young people's eyes, but perhaps this patient was on a medication or had trauma that caused this to become more visible in this patient. So just interesting. Now let's look at what we might see when we're looking at the lens in an eyeball. In the top left-hand side, we see a pseudophakic lens. This is a lens that's been put into the eye during surgery in replacing a cataract. And we can see that it's a nice plastic round lens. It's got a nice reflection to it. The pupil is nice and dilated. In the bottom left-hand side, you see that there's also a light coming from the right-hand side through the lens. But unlike our prior picture, this is nice and yellow, almost a green color, and a little bit opalescent or opaque. This is, by definition, a cataract. So if you're looking at a patient and it doesn't look so clear like this, but it looks more opaque and yellow like this, that is a nuclear sclerotic cataract. We can also see here that in this patient, the lens has fallen. So the lens has fallen inferiorly. This can be due to diseases like Marfan's disease, homocystinuria, or trauma or otherwise. But you see that the edge of the lens, instead of being up inside of the eye, has actually fallen down. And then lastly, down here, we see a cataract, but this is a unique type of cataract that develops after trauma. It looks like a little starburst. I've also seen it be reported after electrocution, but just know that this is a unique pattern, and there's really interesting, beautiful patterns of disease inside the eye. It can give you a hint and a clue as to what was going on. Notably, most of the time when we're evaluating ourselves, our friends, or we're practicing, the eye won't be dilated. But if you look through an undilated pupil at an angle, you can still start to see the remnants of pieces of the lens, perhaps not the whole thing. In the top left-hand side in A here, you see that through the pupil, we see the anterior structure of the capsule of the lens, the cortex, and start to see the nucleus. If we angle it steeper, we can actually see the anterior capsule, the cortex, the nucleus, and I think this is the back of the lens back here. So even in an undilated pupil, you can get a sense of how the lens is doing anatomically. Lastly, let's talk about the vitreous. The vitreous is the clear jelly inside of the eye. I've got to be honest, when I was a med student, I thought it wasn't real. And for a while as a resident, I had no idea what it was, but it is real that there's jelly back here. And sometimes you can see substances behind it. So you have to push the microscope so far that everything else is out of focus, like the iris and the lens. But back here, you see that there are teeny tiny white cells. You can have bleeding and red blood cells. You can actually have inflammation in white blood cells as well. Let's take a look at a video of I didn't choose the the music there, but what you could see was the white floating substance was probably white blood cells floating in the vitreous of the patient. And if you focus far enough back, you can find those types of things inside of an eye. Now, what we're going to do is watch a complete front to back slit lamp exam performed by myself using the technology I mentioned before. And let's just watch it together. You can speed this up, go back to this for reference. And then if you need to, certainly reach out and ask questions. I'll have my email at the end of this lecture. I look forward to seeing you in person and practicing the slit lamp together.
Welcome to the slit lamp examination. My name is Grayson Armstrong. First, let's talk about the slit lamp itself. Make sure that you position it at a height that's adequate for the patient, so they're not bending over too far or stretching up to get to the machine. There's a black mark I'm pointing to here that should match the corner of the patient's eye. Now that the patient's in a good position, flip the switch to turn your slit lamp on, find the right brightness with the knob, and let's begin. Touch the eye cap button on the screen. Let's talk about the eye cap software. This is what you'll see. The start recording button is green until you press it. After you press it, it turns red, which means that you are currently recording. We then press the lids lashes button so that we have adequate exposure for the light on the eyelids. Right now we're moving to the corneal stromal button so that the exposure is set for this thin slit beam on the cornea. Pressing the corneal epithelium button allows us to focus on the front of the eye. It's important that you press these buttons so that the remote eye doctor knows what part of the eye you're looking at. As you'll see in the top left corner, this is labeled right now iris because we pressed the iris button, and that's what we're looking at the moment. The Ocular One device is currently attached to the slit lamp, and there's a tablet off to the side. If you don't have the beam splitter up, you're not going to see anything on the screen. Make sure the beam splitter is up. Here we're going to press the start recording button, and then we press the lids lashes button. This gives us the exposure so that we can see the lids and the eyelashes in good exposure with the light. We operate the slit lamp, as you can see here, just as we normally would, but instead of looking through the oculars, we're looking at the tablet screen. This makes sure that the video is in focus as much as possible. Looking at the actual eyelids, we're moving back and forth to make sure that we highlight all the important pieces. We press the conjunctiva button, and now we're looking at the surface of the eye. We'll talk more about the anatomy later. What I want you to notice is that it's really important to press the button so that the conjunctiva label is up on the top of the screen. We press the corneal stromal button along with a very thin beam. That gives us a beautiful view of a compact cornea, the clear front portion of the eye. Again, we're going to talk about anatomy later, so don't focus on that now. All we're trying to teach you is how to utilize the device. We press the corneal epithelial button, we broaden the beam, and now we can see that the surface is nice and smooth. We can change the exposure by moving the brightness up or down. Here we moved it up to a 7. Pressing the iris button, we can now see in greater illumination the iris details. Here they're quite beautiful on the eye model. We can zoom in just as we normally would on a slit lamp to look at fine detail if we'd like. Pressing the anterior chamber button, we can make a small, thin beam, turn it to the side, and highlight the fluid in the front of the eye. If there was bleeding or inflammation, we would see the cells floating around at that time. But luckily, our model has no inflammation or bleeding inside of the eye. As we change the light source, and as we move to different portions of the eye, you'll notice that if we don't change the buttons, the exposure becomes over or underexposed. Now let's talk about ocular anatomy. What we're going to do is run through each component of the slit lamp examination and talk about what we're looking for. Here you can see that we're currently focused on the eyelids and the eyelashes. In doing so, you can pick up things like eyelid trauma, eyelid lesions, or foreign bodies. Make sure that you avert the eyelids to look underneath and at the edges. That way you make sure that there's nothing surprising hiding behind. In this patient, they have healthy eyelids, healthy eyelashes, so there's not much to see. We press a button, you can see the label change to conjunctiva. So now what we're doing is looking at the conjunctiva and the sclera, which is the surface of the white part of the eye. You'll see small vessels, but what we're looking for are things like trauma, foreign bodies, eye redness, mucus, or discharge from infection. When people have injection on the surface of the eye, that can be from anything from allergies to viral infections to bacterial infections. It's important to sweep the entirety of the eye. You want to look at the top, the bottom, the left, and the right side of the conjunctiva and sclera. You might be surprised to find history of prior surgery on the surface of the eye, or things like foreign bodies hiding on the surface. Now we're looking at the corneal epithelium. This is the surface of the clear part of the front of the eye. Here you can identify things like corneal abrasions, foreign bodies, lacerations of the cornea, and even infections from contact lens use or otherwise. These are otherwise known as corneal ulcers. In this patient, they have a nice, clear, compact stroma, and so what we're going to do is make a very thin beam. At the side, it's pointing in and showing us a tight, compact corneal stroma. You can see in this cross-section that the thickness of the cornea in this patient is normal. It has good structural integrity. There are no holes or lacerations, and there are no foreign bodies present. Now we'll look at the anterior chamber. This is starting to have a high exposure on the video. What we're looking at is the fluid between the cornea and the lens. We're not focused on the cornea or the lens, but the fluid in between. If there was bleeding, cell and flare, or an infection, you would see the cells floating in that space. We'll now look at the iris. The iris is a beautiful structure. In this patient, it's brown, and you can see the small crypts on the surface of the iris. Every single person's iris is different from the next. And so it's a very beautiful structure, but also important to look at for things like diabetic changes and otherwise. We make a thin beam and we focus on the lens, which is right behind the iris. And in this patient, you can see they don't have a cataract. It's nice and clear. And if they were dilated, you could see the anterior vitreous. Again, my name is Grayson Armstrong. Thank you so much for spending the time with us today. We hope this answered all of your questions, and we're happy to answer any more that come up.
So that concludes this lecture. I hope this was helpful, and I look forward to having you practice on slit lamps as a medical student, and certainly as a resident and beyond. It's an amazing skill, and even if you don't end up going into ophthalmology, it's useful for people in other specialties such as emergency medicine, internal medicine, and beyond. So keep this as a reference if you'd like, but feel free to reach out to me with anything that you have, any questions, concerns, or otherwise. My email here is grayson_armstrong@meei.harvard.edu. It's been a pleasure, and all the best. Bye.